Good evening. Welcome to our second Macular and Me session for this year. This is the side for people of a working age, or a bit more of a working age focus. Let's put it that way. I know we have sort of the age groups are well spread. So it's last month we had our cost of living thing, which I do from time to time, but we've gone back to a clinical evening this evening. So we're back to our usual. So the little voice in the background from time to time you might hear, just if you hear, that's my support worker Jess. So she's running the show. It looks like I'm doing everything, but I'm not really. So there's a bit of housekeeping before I introduce the other couple of people with us. So we're on a full webinar package, so you can't unmute yourselves and you can't share screens. So don't worry about any of that malarkey. Jess has set the chat up, so I know that Professor Tunde Peto will take some questions later. So if you've got any questions for her, if you can pop them in the chat, that would be marvellous. And that leads me delightfully on to my colleague Jerry. Hi Jerry, how are you?
I'm fine, thank you. Welcome everybody.
Welcome, great. So Jerry, as people that have joined us before will, as she will attest, I don't do very much for these. I just do the highs and the hellos and introduce people. So a bit later on, Jerry will ask the professor some of the questions that you put in the chat. So I'm sure you'll come up with some great questions. So are you ready for all of that, Jerry?
Yes.
Marvelous. And I think a little update on research, just because it's the first clinical one of the year, would be good as well at some point near the end. Is that okay? Brilliant. Okay, perfect. So as you know, these webinars are all about all aspects of living with macular disease, from technology and day-to-day stuff, but there's a real focus on clinical treatment and research, and that's what we have this evening. So I'm very pleased to introduce Professor Tunde Peto, sorry, excuse me, Tunde, from Queen's University in Belfast. To give us a chat this evening. So hi Tunde, how are you?
I'm very well, thank you, and thank you very much for having me tonight, and lovely to see people again.
It is great.
It's been great that we had a couple of face-to-face events, but I think there is a real value in having some of these events as well dotted around the yearly calendar.
I find these great. I mean, we know that people from all over, just all over the world really come and may not log in the evening, but we can watch so much again, so they're invaluable to the work that we do at the society, and we're very, very grateful that you've spent the time this evening to come and join us. So I think I might just leave you to take off, really, get on with it, really. So I'll hand over to you then, Professor, and I'll mute myself. Okay.
Okay, so I'm going to share my screen, which of course worked when the practice run was. So hopefully it works again, and hopefully you see my screen full screen. So I'm going to be discussing some of the issues around macular disease. And as you know from yourself and probably from your loved ones, that macular disease takes on quite a number of variety of diagnosis. So I thought that first we can go through some concepts that will help to understand why we sometimes don't just worry about the retina, and then also to go through some of the pictures as well and what we do. I will try to talk you through as much as possible, but I do know that usually we have a varied audience of sighted and not so sighted people, and sometimes we have the carers and the family members sitting with people. So it's sometimes just really good to understand what your other half or your children or your parents are going through. So what sometimes we forget, that while we look at the eye, your vision doesn't actually come from the eye. You know, it comes from the interaction of your eye and the brain. And when the light comes into the eye, it will go all the way through to the very back of the eye, and then it will come back. And some of you might have rod cone dystrophy because it's more common in the working age group. And those are called photoreceptors. And these photoreceptors, they are responsible for several of your types of vision that you have. And depending on which ones might be more affected, you might have different issues. One of the very common misconceptions is that we have cones in the macula, and the macula is the center area of the eye that is responsible for the more detailed seeing. But in reality, we have lots and lots of rods in the macula as well. So you might find that you have a different dystrophy, but you still have your central vision affected. So the rods are most numerous in the periphery. They provide your night vision, and they see all shades of gray and white, and they see in dark and around us. So predominantly, if predominantly the rods are affected, then you might have very good vision because the cones are responsible for the detailed vision, but it doesn't mean that your vision, central vision, might be perfect because the area where the cones are is quite small. So both laser treatment, if you had diabetes and you needed to have laser treatment to the periphery of the eye, and if you had some diseases such as Marfan syndrome or some other diseases where retinal detachment is common, they might affect the peripheral retina as well. So the cones which are responsible for our colored seeing and also for the detailed seeing, they are very numerous in the macular center area. But we have to appreciate that as far as we understand, you need very few for good vision. And this is important because sometimes just rescuing those few cones or losing few cones that we might not even be able to appreciate when we look into the eye. So you appreciate that your vision has gone down, but we can't really see the change. That might be because some of those remaining cones have died. So just to give you a little bit of understanding, these rods and cones, they truly look like rods and cones. So the cones have a little conical shape and the rods are sort of very, very long. And what happens with the vision is that once the eye gets all the light information, it has to go through the whole of the brain to arrive at the very back of your head. And this is where the occipital or the visual cortex is. And why is that important? It's important because some people have completely normal eyes, and you might think that you have an eye disease, but it might be that you got knocked off the bike and you hit your head, or you had a small stroke or something like that, and you can't see. In those cases, it is usually the visual cortex that gets damaged. But for some people, it might be that certain diseases will damage the visual pathway, and the eyes might look completely normal, but the pathway doesn't work because the connections don't work. The reason I wanted to bring this, sort of just talk you through it a little bit, because a lot of the times the eye is fairly normal, and we really have very limited number of treatment, if at all, to be able to treat some of the issues around the visual pathway. But sometimes there is an interaction between the visual pathway and the eye, such as, in diabetes, getting the blood sugar down will help both the brain and help the eye. So sometimes we have a very significant change, both in how well the eye functions, but also, even if you have diabetic eye disease, if your brain functions better because the diabetes is well controlled and there is no high blood pressure, the way you perceive the signal and you perceive the way that the vision is might be very, very helpful to enable people to see. So some of you with my date of birth or worse, better, whichever way you want to look at it, if you're enjoying lovely retirement, you know that we used to look at the back of the eye with just an ophthalmoscope. We shine lots and lots of light into the eye, and we would make a decision, or we do some lots and lots of drawings, and we try to figure out what's been happening based on comparing our results to previous drawings. But you might not be aware that ophthalmology is now officially the busiest subspecialty. We are responsible, and we are a fairly small subspecialty in numbers. We are responsible for the 10 to 12% of NHS outpatient appointments. Okay, so it is a substantial workload that we have. And of course, if you have been to an eye clinic, you know that we are not doing it alone. We are task sharing with some of the optometrists and the nurses. We have shifted some of the tasks, such as the intravitreal injections, to the nurses and the optometrist or orthoptist. And they're very, very valued part of the team. And they're very well trained. So you might come to the eye clinic and meet a consultant ophthalmologist or a doctor every now and again when we need to review your treatment or inform you about new treatment opportunities and discuss the risks and the benefits. But in many, many cases, we have a big team around us to help us to get to the diagnosis and the best treatment. So we then started with photographing the back of the eye, and if you're lovely and young, then you might have a few drusen if you're healthy, or if you have a central ear. And then we also do what we call an autofluorescence image many times. Those of you who used to see, this is a very good image in a sense that it's only black and white. A lot of people can see enough that we can explain the disease, and we will be monitoring a lot of the geographic atrophy patients, and we will discuss that later using this technique, because other than the blood vessels and the optic disc, which is where the information goes from the eye to the brain, other than that, we really shouldn't have big black patches. Anything that's big and black patch is not good, and usually we can explain the disease if it affects this part of the eye. So we can image in these cases the nourishing layer of the retina, the retinal pigment epithelium, and of course it's understandable that if you have no nourishment coming into the eye, then the retina, the seeing part of the eye, will really suffer. And that's what's happening in some of the macular diseases. So those of you who come to the eye clinic, you know that we take the color image, which is a color image here and another color image there with a big white thing in the middle. But then for a lot of diagnosis, we need to be taking what we call fluorescein angiography. We might not do as much as we used to because we have a new technique called OCTA, which is an OCT angiography, but it doesn't quite show everything that fluorescein used to show us. So the big white blotch in the middle shows that there is a lot of trouble, and this patient would have had treatment for the eye. And some of the macular degeneration patients, you probably wonder, we treat the center of the eye, but in some patients, there is some night vision problems as well, which is not uncommon in elderly anyway. But unfortunately, we do know that some patients with central macular disease have some peripheral disease as well. The in-between area is lovely and healthy. So navigation-wise, it would be perfect. But sometimes the night vision isn't quite as good. So at the moment, we have a fair few drugs to treat macular disease. And even if you have some of these varieties, but what would give you wet macular disease type abnormality, such as in some of the myopic changes, some of the pseudoxanthoma elasticum cases. So cases where you're much younger than our average patient, you might be getting these injections as well. And we have now quite a few choices that we can make, and more are coming. So it will be well worth having a discussion with the treating doctor as to what they are able to offer. Some of those choices will not be available for a few more months probably, but we have more drugs than we had before. They're not necessarily very different for this disease. So, and we have very, very safe drugs at the moment. So we don't necessarily have to switch people. And I think that's a very important message, that a lot of the people will keep going what we had before. And then, of course, in some cases, we will be treating people for 7-8 years and making sure that we have a lot of good results. So in those of you who can see, you will see on the top layer that's vessels in the center of the eye. And this is OCTA when we don't have to inject the yellow dye. We are able to see the vessels without the injection, but it doesn't quite work in every case. So we've got to make sure that we get good pictures of the back of the eye. So a lot of the macular diseases eventually end up with what we call atrophy. So when the back of the eye, when the layers of the back of the eye die away. And one of the most common one is geographic atrophy. And as the population ages, and as we have more and more of us have to work into sort of well into the 60s, we are seeing more and more people in the working age group to have geographic atrophy. It's sometimes not as easy to appreciate on the color image, but those holes in the middle are, like that. But if I show you the black and white image, which is the autofluorescence image on the right-hand side, a lot of you, even sometimes with fairly poor vision, you can see that there is a big black patch in the very middle. And that would all be areas where the patient couldn't see. A lot of the macular diseases that are ongoing, juvenile macular degenerations, a lot of them end up with some degree of atrophy. And atrophy means that area has died away. And in many cases, we have very little treatment to offer them. However, you probably heard on the radio, and I haven't checked, I should have, I'm sorry, if it's on Macular Society website, there is now one treatment approved by the FDA in the US last Friday. They approved the first drug for treating for treating geographic atrophy, and you need to watch out for the big hype. It doesn't treat the disease. Treatment is understood by most people that it will go away, the disease will go away. It slows the progression of the disease to a sufficient level that it is much less fast progressing, but it doesn't give those areas back where we have where there is already some dead tissue. So it's actually something very different to what we understand as treatment, because it's not really treating the abnormality, it is slowing the progression of the abnormality. So Geraldine, I don't know if that one question that came in is related to this. I'm happy to stop here because I was going to move on to diabetes and a couple of other things. Or do you want
No, I just wanted to flag that and I'm going to put a link in the chat function, that we have issued a news item on pegcetacoplan, Syfovre is its brand name. So we have started to tell people about it. We're still learning ourselves about how it might be used within geographic atrophy associated.
Yes. So I think that's very important, and I think it's very important that we manage expectations. So unfortunately, if someone has lost sight in both eyes, this drug isn't going to get the lost sight back. And that's a very different proposition to what people usually understand as treatment. and also what we have in wet age-related macular degeneration, that a lot of people will get better. So we are learning, this is the first drug. A lot of trials in atrophy have failed over the years. This is the first one that has managed to do this. I'm sure there will be others coming, but I just wanted to say that we are very cautiously optimistic that we will be able to offer treatment, but none of us have a lot of experience on treating the disease.
It's very exciting. It's great. Things are moving so fast. It's amazing. Jerry, have we had any questions so far in the chat?
No, I posted the link to the news item.
Oh, okay, that's what that was.
And
okay.
yes, we've been liaising with the company that makes this drug, Apellis. We've got an ongoing relationship with them, so we're keeping a very close eye on it. Yeah, it's early days. Yeah.
Brilliant.
Yes, and I think that's very important, and keeping it in perspective is very important. And they have actually been very good about that as well. So hopefully that will long may continue.
Oh,
so I'm going to just talk a little bit about diabetes, because unfortunately we have diabetic eye disease in the UK a lot. And when you come to an eye clinic or go anywhere else, you will very likely to be meeting some eye doctors. But you have to remember that when IDF, the International Diabetes Federation, has done a big survey of 41 countries, it turned out that although about 1 in 5 people have their vision impairment, that makes diabetes management very, very difficult. But a lot of people have never really discussed this disease and complication with their doctor until the onset of the symptoms, which is usually quite late in that disease. People with diabetic macular edema and diabetes-related visual loss and eye disease, they tend to have much poorer physical and mental health. And what is really hard to believe, and in the UK, this really wouldn't be the case, but you have to remember that people they don't all live in the UK. About 1 in 5 eye doctors around the world never receive specific training in treatment and diagnosis of diabetic retinopathy and diabetic macular disease. So no wonder that in a very common disease that can steal your sight, it's a real worry. So in diabetic eye in the UK, we're very, very fortunate to have diabetic eye screening. And diabetic eye screening has given us a lot of opportunities to make sure that we understand who we should be treating, who we should be seeing. And some of you or some of your families might be moving over to a 2-yearly interval if they haven't had diabetic eye disease for 2 consecutive years. So that's not going to be, and that's not a knee-jerk reaction to COVID waiting list. If COVID didn't happen, pretty much most of the UK would have moved to 2-yearly intervals for people who have had no diabetic eye disease for years. But on the 1st of April 2020. But of course, we went into lockdown and everything had to be changed. So you will be seeing some changes. And when you come to the clinic, we will take a normal picture, but some of you will have a funny picture taken as well with a camera that's called Optos, that you put nearly all of your face into it. Some of you might have experienced it. It's not just a chin rest, it's sort of half of your head goes in. And that gives us a much bigger view of the periphery. We can see much more details. And this patient had a lot of laser treatment. All of those little dots, and those of you can see it, they are all lasers in the periphery, because we would treat the periphery changes in order to save the center of the vision. And this is a good long-term treatment. There are a lot of people with 50 years of diabetes who have been lasered 40 years ago, and they still have good vision. Of course, we need to do it, when the vision is still good, because it's much easier to save good vision than get it back. And then there are some other cameras. This camera, you might have had an experience with it. It's called an eye-on camera. It's a little bit like a spaceship, and you can, it talks to you and that tells you which way to look, which is great, that you can do all your own imaging potentially when you get to the clinic. So if you have diabetes-related maculopathy and macular changes, on this picture, on the top, you can see that on the right-hand picture, everything is nearly white. That just means that every single vessel in this is really, really sick. And the patients still have very good vision, 6/9 vision, but a lot of fluid in the back of the eye. So we would start treatment. But of course, sometimes when there is so much trouble, the retina goes very, very thin, and the retinal photoreceptors die away because they can't take the sudden change. So this patient unfortunately have lost vision when everything went back to normal for the diabetes and everything. Sometimes we ask you to get your diabetes and the kidney disease and everything under control, because sometimes that's enough for the fluid to go away. So we might not start treatment immediately. And that's a concept that not always easy to understand why we wouldn't treat. But sometimes we think that the amount of trouble that people have might just clear up on its own if the diabetes, the blood pressure, the lipids, and kidney functions are all normalized. But what we always have is, both in every disease, macular disease, we would always have what we call an OCT, an optical coherence tomography image. And we do it because this shows us the back of the eye, and it's like taking layers of the back of the eye, like histological samples, every 10 micron. So it gives me a lot of confidence as to what I'm seeing is real. And I would be looking at every single layer of the back of the eye to make sure which layer might be in most trouble. And the reason some of you might be wondering as to why we are sometimes even imaging the non-seeing eye. And we do it because if for example, I'm not there and you attend what we call a virtual clinic, if there is no image of the second eye, I don't know if the photographer didn't take it, but if our camera was faulty, if something happened to you and you got sick and couldn't tolerate the second eye, or it's simply an artificial eye. So if there is no image of the second eye, then I need to go and find out why, and I have to ring you and say, do you know why your second eye wasn't imaged? And you say it's an artificial eye, but then I feel really silly about it. But it might not be in your notes because you had it for so long. So we would always take an extra image. And then we will be looking through every layer. And those of you who can see a little bit, I try to put in big black holes because that's usually quite easy, easier to see. In the lower image, you can see that there is a lot of fluid in the back of the eye. And again, when it died away, then the layers of the back of the eye have become disorganized. So the patient, unfortunately did not get much better vision because the retina could not take the damage any longer. So it sometimes is just how things go. And we would discuss it with people, but there are lots of drugs now that we need to consider. So we will be talking to people every time when we think that this drug isn't working and we might need to switch. So just to finish off, because I'm conscious of me talking for far too long. So just to finish off, those of you can see, this is a distorted map of the world. And the top shows where the words blind people are. So it's very distorted for Africa, Southeast Asia, China, and Europe is just a little sliver. And when you look at it where the words ophthalmologists are, Africa becomes a tiny little sliver and Europe is fairly big. So our research and what we do always try to work on it for the benefit of other people as well, and make sure that we are able to transplant our knowledge. We get a lot of trainees from elsewhere as well to make sure that they go home and they are able to treat their patients as well. So sometimes you might find that you have a foreign doctor in the clinic as well, and we would be showing them even some very common cases, just because what's common here might not be very common to them. I'm currently working with the neglected tropical diseases in Geneva, and river blindness is very, very uncommon here, but it's very common in the Congo and the Gambia and a few other places. So for us to be able to help out with treatment provided for some of those diseases, we need to have a very good understanding of our diseases here. So I hope it's always quite hard to figure out what might be helpful, but hopefully I provided you with some insight as to what our thinking process is. Sometimes people get a bit upset when we ask for an extra imaging, because that will give you another 10-15 minutes sometimes in the clinic. But we usually have a very good reason as to why we would want extra imaging. We probably want to see a certain layer of the retina, or we want to see we want to understand how the nourishing layer of the retina works, what we might be able to salvage, and how much the potential visual gain might be. And for those, we need to have the full documentation. And believe me, those imaging equipment are now very, very good quality. So they really help us to be able to provide you with a much better understanding of what the disease might be and what the outlook might be. So thank you very much for your attention. Sorry, I have spoken about 4 extra minutes, but hopefully it wasn't too bad.
Oh, Professor, that was really interesting. I really thank you. That was you explained everything so well and so clearly. It's great when we have sessions like this, because everybody learns stuff. It's brilliant. So thank you very much for your time. Jerry, I heard Jules, my little screen reader there, was waffling on a couple of times. So I think we've got a couple of questions in the chat, haven't we?
Yes, we do. I'm going to take the one from Bernie first, because she's saying she's having to rush off for another meeting. And she may have gone already, but she's asking about diabetic macular ischemia. And potential for treatment, because I'm not sure there is a treatment at the moment. Could you say a little bit about that form of diabetic?
No, so diabetic macular ischemia is something that nearly every patient with diabetes have some sort of ischemia, a little bit at least, because diabetes affects the small vessels in the back of the eye. And what happens is that in those cases, the very center of the eye doesn't get enough oxygen and nutrients. Unfortunately, at the moment, we cannot sort this. Young people tend to cope with it better as our date of birth is getting less favorable. That tends to, that our ability to cope with it, the circulation, the rest of the circulation around that area tends to get worse. And unfortunately, at the moment, we have no treatment. And that's unfortunate, because in the eye, we can see it, but we do know that someone has very significant diabetic macular ischemia. A lot of those people tend to have some ischemia in their heart or in their extremities, in their feet, in their kidneys. So when we see some of that, then we usually ask people to be followed up in their diabetes clinic to be able to lessen the chance of any other complications.
Thank you. And just to clarify, ischemia is loss of blood vessels?
So when you have ischemia, yeah, you have areas where the blood vessels are either completely shut down or the flow is so slow that we can't measure it.
Thank you. Yeah, I think some of the pharmaceutical companies are working towards and hoping to develop something in that area, because they see it as an unmet need, which absolutely.
It's a massive unmet need. Yeah.
Lovely. Thank you. I'm sure Bernie will catch up with this on the recording.
I'm sure she will.
Exactly. So a query from Thelma. She's asking about, and this is a good one actually, because we talk about macular degeneration, but macular degeneration or macular, atrophy can be related to a number of different causes.
Yes.
So she's asking about dry AMD due to dry AMD and myopic macular degeneration, and how easy is it to determine a patient has both conditions? Can you tell what the cause of the atrophy is? So
usually it's extremely rare that you would have a pure geographic atrophy without drusen. Drusens are little concretions in the back of the eye, like little yellowish dots. And we can see the aura layer and the retina on the OCT. So we can usually do, when we do an OCT, it would be extremely unusual for someone to have geographic atrophy related to AMD without drusen. And also both GA and myopia, they tend to be quite symmetrical in a sense that it's unusual for both to have one eye really badly affected and the other eye being completely normal. I mean, you usually have a bit of a difference between the eyes. Also, if you have myopic macular degeneration, most people know that they have been myopic for a long, long time. It would be very strange for that myopia to come on, affecting the retina unknowingly when you are in your 60s or 70s.
But you can have both conditions. It's not impossible. It's just very rare.
Well, it is very rare at the moment. The myopia is termed as the third epidemic because so many of our young people have myopia. In Southeast Asia, it's pretty much completely normal that everyone is myopic. So people are they're working very hard on slowing the progression of myopia in young ages, because then once the eye is fully developed, it's unlikely to get, from -2 to -15 or something. But in youngsters, it can go quite fast. And I think with this coming in, we will be seeing more dual disease in years to come.
Yeah, it's something we're very concerned about at the Macular Society, and we want to really focus on it in a minute. We haven't quite figured out what exactly, but we are quite concerned about it as the next.
We are very concerned about it in a sense that it affects much younger age group. You can have atrophy. We usually can tell it apart, but it's an academic discussion, because if the center of the vision is gone due to atrophy, whichever disease, it's gone at the moment. And also because the cracks that can develop, that the cracks can develop, they can mimic that age-related macular degeneration as well. Fortunately, the disease tends to respond very well. And Thelma, I've seen your incoming message. You have some drusen as well. Pretty much everyone over the age of 40 has some drusen. So I don't know your age, and I'm not going to ask in the big audience. But if it would be very, very unusual for people not to have at all any drusen.
Thank you. That's great. So somebody else is asking about the different treatments for diabetic retinopathy. So you've got a variety of treatments: lasers, anti-VEGF injections. Could you talk that through a little bit more for us?
So laser to the periphery is the definitive treatment, because laser will last forever, pretty much. And we have patients who were lasered 30, 40, 50 years ago, and they're still going strong. So although laser has side effects in the sense that it will give you lots of small atrophy on the periphery, the new lasers are nowhere near as vicious as the very old lasers were. They were much more difficult to titrate. These new lasers we can titrate much better. The downside of it is that we sometimes have to give you supplementary treatment, which we very rarely needed to do in the olden days. We try to treat as much as needed and not more. There are drugs, there is anti-VEGF that will close the vessels down, but they will reopen if you don't do the laser. And we do know that if people are very good at coming in theory, we could treat proliferative diabetic retinopathy with anti-VEGF. But we know from several studies that if people somehow got lost to follow-up, or God forbid they had a stroke or a heart attack and we couldn't inject, because we can't inject after a heart attack or a stroke for about 3 months, then the disease came back with a vengeance, and we have had trouble. We would have trouble then going after that very active disease, especially if someone is in hospital with a stroke and a heart attack. So we principally, and a lot of the times we combine the two in some cases that are very, if it doesn't come down as easy as we would like, because then the anti-VEGF injections will close the vessels a little bit for a time. We manage to get the laser on, and then they don't come back as much. And then eventually we manage to calm the situation down. But at the moment, we have laser as a definitive treatment.
Thank you.
Anti-VEGF really helps a lot of the times, but unfortunately, it's not as helpful as we would have liked.
Okay, thank you. So somebody else has asked, Jackie, if you have a problem in one eye, what is the chance of developing in the other? I imagine that's different for different diseases, or is it much the same?
Yeah, so you have to remember that the eye bathes in the same fluid. It would, most cases, I know that there are some exceptions, some very rare genetic things, but with diabetes, okay, brilliant. So it's extremely rare for diabetes to be very severe in one eye and nothing or extremely mild in the other eye. If that happens, we usually think about if you might have had a little stroke in the eye, or if the vessels in the neck and on that side where the eye is very severe might not be. So it's funny when we send people to a carotid ultrasound, the carotid looks like when people are pregnant, and it's just a little probe. But so these people sometimes get really surprised when we send them to these examinations. But we do it because if one eye is very severe and the other eye is minimal, then we would be concerned that somehow the circulation around a much more seriously affected eye is compromised and is not as good as we would like it to be. So usually the two eyes are fairly symmetrical with little difference between them. So if for example, if someone has a severe non-proliferative change in one eye, the other eye might be mild to moderate, but it's unusual for it to be completely normal.
Thank you. That's fascinating. I hadn't heard that before. I mean, obviously diabetes is something that affects the whole body, and that really brings it to life that I wasn't aware that circulation could have that much effect on how one eye was affected and not another. So thank you. We've run out of kind of questions in the chat, but I had a few thoughts, if you don't mind me having a go. It went back to what you were saying at the beginning about very few cones are needed for good vision. Can you elaborate on that a bit? I mean, there must be millions of cones in the retina. So how many is few?
We don't really know. I mean, there's been always an ophthalmologist joke, which is probably, I don't think it's true, but people are saying that, you have 8 or 10, you probably will be able to see straight ahead. We don't know, but some of So the good thing is that we're now getting cameras, and not quite in every eye clinic, but pretty much a lot of the very good research centers would have what we call adaptive optics. Adaptive optics is now available for normal use. Previously, it was just massive rooms with an optical pad, and it took 2 hours to sort of adjust it. Those people were extremely clever, and they got very good images, because there are so many aberrations, things that would reflect light in our eye, that by the time we get to the bottom of, the very back of the eye, we couldn't quite discern those tiny little cones and rods. At the moment, with the normal commercially available assistance, we can now see cones. So I think this question will be answered, once we start imaging all kinds of diseases. We're imaging at the moment quite a few patients with multiple sclerosis, because they, of course, have a lot of visual problems, and we always thought it was just the optic nerve being inflamed, but it seems that there's some retinal involvement as well. And we are imaging different diseases, exactly trying to figure out what is it, what would we, because it's a very good question, Geraldine, because we might not have to be able to save all the cones for someone to be able to navigate and see and function. We might be too ambitious by trying to save all of them, because we won't be able to. And that also, if we ever have transplants, we might not have to transplant 100 million cones. If we can transplant 200,000, and someone can have good vision with that, that would be amazing, because we might then be able to get that many from somewhere else in the eye. 500 billion, we can't get somewhere else from the eye.
Because they have tried to transplant bits of the retina into the macula, but I gather it didn't work. So
you have to remember that a lot of the times, by the time those transplants went on, the nourishing layer of the retina wasn't that great either. So I think our understanding of the relationship between some of the retinal cells and the retinal pigment epithelium and the choroid, I don't think we are completely there yet to understand why something really works.
Okay, fascinating. So we haven't got any more questions in the chat, so do put a few more in, but I have some of my own. Another one. Obviously, we're talking a lot about the different ways in which you can see what's going on at the back of the eye, and that helps your diagnosis and how you do treatment. Can you explain a little bit more about the normal kind of OCT that everybody's familiar with, and OCTA, and what are the differences between normal OCT and OCTA? Because I think we are increasingly seeing people using OCTA to support diagnosis.
Yeah, so OCT itself is like slicing the back of the eye using light, and the light will come back from every layer of the retina. So just if you imagine that you shine light onto multiple layers, some little light will come back from every layer, and that's what then we have a look, and the layers of the retina will be looked at or will be imaged. When we do OCTA, there is like a little bit of a time delay type stuff, and then it measures the flow of what's in the blood vessels. So this is why we can't measure too slow flow and too fast flow. There is really no too fast flow, because there's no possibility of the blood flying around in the body for that that fast. But sometimes we don't know if somewhere there is seemingly no flow, if it's just too slow or it's truly not there. So it's a very interesting way of looking at some of the blood vessels. Some of the adaptive optics machines, actually you can see, it is so stunningly beautiful. You can actually see a red blood cell marching ahead in the vessel. It is just beautiful. And the good thing about it is that we will be able to then look at something like sickle cell disease, you know, are we impacting on the underlying disease, or proliferative diabetic retinopathy, or is there really a chance for that area to be revived? Because if there is absolutely no flow in that area, there's no flow in the choroid, you can put something on it as a transplant, for example. But if it doesn't get oxygen, doesn't get nutrients, doesn't get any blood flow, it's going to be very difficult to keep those cells alive. So it's going to give us some very, very detailed understanding as to what we even might expect.
Thank you. That's brilliant. Okay, a couple more questions have come in. How common is it for a young person around 20 years old to lose sight due to diabetic retinopathy?
It's very, very uncommon, but it's not impossible, unfortunately. The longer someone has diabetes, the more likely that people have bad diabetic eye disease. And of course, we know that sometimes people get diabetes when they are babies. You know, I've got, you know, patients who had that since they were a few weeks old or a few months old. So by the time they get to their 20s, they had diabetes for 20 years or 19 years. So, and then also we know that being a teenager is very, very, very hard at best of times, even for people without diabetes. But to have diabetes and be a teenager is extremely difficult. And very few people have completely good diabetes control while they are teenagers. So those few years during teenage years can have a significant impact as to how quickly someone will develop high risk proliferative diabetic retinopathy or ischemia or maculopathy. In women also, pregnancy can very much contribute to it. And we know that people have a high chance of losing sight if they had, or having high risk disease if they have had severe disease before pregnancy, if they weren't prepared for that pregnancy, so that diabetes control wasn't great. That's why we see how much diabetic retinopathy is there before pregnancy. So we would very, very closely monitor those patients.
Thank you. So we've had a couple of extra questions which are focusing on myopia. Why does eyesight continue to become more why do people continue to become more myopic in older age? Most of the myopia develops as a child, as I understand it, but that doesn't mean your eyes are static for the rest of your life, does it?
No, so there's sometimes a myopic shift when you start developing cataract as well, and sometimes it's just the sheer fact that some of your refractive error wasn't fully corrected, and your brain could make it up, or your muscles, because you were young, and then suddenly you're not so young anymore. And it's much more difficult to accommodate and also make it up. And then of course, for the new generation, it's the lack of daylight, the close-up work. COVID certainly made a lot of kids myopic because they were sitting at home, especially those who had lived in apartments and didn't have anywhere to go. So it's going to be a huge issue.
Mm. I mean, Edward has sort of said he didn't appreciate the size of the growing problem of myopia, and I think there's a growing awareness, but there needs to be more probably. So yes, we have featured myopic macular degeneration in other webinars.
Brilliant.
They will be on the website and recorded, but you will see us talking about it more as time goes on.
It's definitely becoming something we're focusing on alongside diabetic macular edema. So yeah. I'm just aware of time. So I was just sort of butting in for that reason, really. So have we got any other questions for in the chat?
No, that's all.
Well,
yeah.
In that case, I think I'll draw the Q&A session to a close, just to give you a couple of minutes just to chat about our research stuff before we close. So, Professor Tunde Peto, it's been a really interesting session this evening. You've explained everything very clearly, and I, for one, have learned so much tonight, and I'm sure everybody else has as well. So, really thank you for your time this evening.
Thank you.
Well, great, brilliant. Honestly, it's great. This is going to get watched so much. It's when it goes up as well. So I'm really grateful. So thank you. So Geraldine, do you just want to sort of do your research project thing? And
do my cell. Yes.
Yeah.
So yes, I'm the research manager, but the exciting thing that I can talk about today, as well as other things, is we have a new research director. So we've never had a person at a director level before. And I think this indicates, the commitment to fund research and to support the development of new treatments for macular disease. So he's only been with us a month. He's called Peter Bloomfield, but he's going to be focusing on our new research strategy, on what more we can do. At the moment, we fund research projects at universities, hospitals around the UK, but I think you'll see our research programs expand into new areas and over the coming years. So it's part of our real commitment to research that we're moving in that direction and expanding our research program in the coming years. For anybody who wants to get involved in research in any way, that can be hearing about clinical trials that they may be eligible for, or taking part in surveys, or being on an advisory panel and giving researchers and pharmaceutical companies the benefit of their experience of having macular disease, because there is a lot of people are coming to us all the time asking for patient input into what they're doing. That's another way you can get involved in research. So if you're interested in doing anything like that, we have our research participant database, which you can sign up to on our website in the research section. And we would take a few details, nothing very onerous. And then, as we get requests, for instance, somebody with myopic macular degeneration, we can see that you're interested in hearing about opportunities, and we would get in touch with you direct if we had an opportunity we thought you would be suitable for. But even if you didn't sign up onto the database, we regularly advertise opportunities on the website, usually flagged in our monthly e-newsletter. And there's all sorts of ways in which you can, from the comfort of your home, take part in research and contribute to research. So that's my advert for that. We have a lot of opportunities available for people, and we need lots of it. So we have about 4,000 people on our database at the moment, but it's growing all the time.
Brilliant, beautifully done as always. That's great. Sign up. There's just so much going on. It's fantastic. Anyway, so we've come to the end of this very interesting evening, and so I'd like to thank everybody for coming. Jerry, as always, Professor Tunde Peto, thanks ever so much. It's been great. If you didn't catch all of it, or you want to watch it again, because I know I am going to watch this one again, it will be available on the website and also on our YouTube channel. So if you subscribe to that, you'll find any new videos, or just ping up on your whatever device you use to watch YouTube. The next month we're going to be talking about, I'm just trying to remember who it is now. Oh, yeah, there we go. Dr. Robin Walker, who's going to be coming on and talking about Charles Bonnet syndrome, but in young people, which will be quite an interesting, because generally people tend to think about Charles Bonnet in people who are just that little bit older. A less favourable birthday, as Professor Tunde was running all evening, which I thought was great. It just made me giggle. Because I'm 50, I don't know which side of that I'm sitting on, if you know what I mean. Anyway, so but it's
still young.
So it's brilliant. Okay, well, fantastic. It's been a great evening. So our usual places to register for that, it will be in the e-newsletter, as Jerry mentioned, and also, as I say, subscribe to the YouTube channel. There's loads of great past videos on there as well. So